Hello friends, welcome to Studental. I am Dr. Salman Ansari, your mentor for today, and the topic is gingival enlargement. First, we will see the definition of gingival enlargement. Increase in size of gingiva is called as gingival enlargement or gingival overgrowth. Here in this picture, you can see the increase in the size of the gingiva or the gingival sulcus. This leads to the formation of pseudo pocket, thus causing the accumulation of plaque and debris and thus leading to increase in the inflammation. In this picture, you can see the increase in the size of interdental gingiva and the marginal gingiva and also the attached gingiva. In the maxillary arch, you can see the increase in the size of interdental gingiva and the marginal gingiva. So, increase in size of gingiva is called as the gingival enlargement or gingival overgrowth. Before coming to the classification of gingival enlargement, first we will see two terms, that is hyperplasia and hypertrophy. Hyperplasia is nothing but the increase in the number of cells, and hypertrophy is nothing but the increase in the size of the cells. So in hyperplasia the number of cells are increasing, and in hypertrophy the cells are the same but the size of the cells are increasing. Coming to the classification of gingival enlargement. Gingival enlargement is classified as inflammatory enlargement, which may be chronic or acute, drug-induced gingival enlargement. Third is the enlargement associated with systemic diseases or conditions. Under systemic conditions, there are pregnancy, which is a hormonal condition, puberty, which is also a hormonal condition, vitamin C deficiency, which is a nutritional condition, plasma cell gingivitis, it is an allergic condition, and non-specific conditional enlargement, that is pyogenic granuloma. Coming to the systemic diseases causing gingival enlargement, such as leukemia and granulomatous diseases like Wegener's granulomatosis and sarcoidosis. The fourth is the neoplastic enlargement, that is the gingival tumors. The tumors may be benign tumors or malignant tumors, and the last is the false enlargement. Gingival enlargement can also be classified depending upon the location and distribution. Gingival enlargement can also be classified as localized, which is localized to a specific area, generalized, which involves all the area, marginal, that is involving only the marginal gingiva, papillary, involving only the interdental papilla, diffused enlargement, involving the marginal gingiva and the attached gingiva, and discrete tumor-like enlargement. Depending upon the grades, depending upon the degree of gingival enlargement, enlargement can also be classified as grade 0, that is no signs of gingival enlargement, grade 1, that is enlargement confined to interdental papilla, grade 2, enlargement involving papilla and marginal gingiva, and grade 3, the enlargement that covers the 3/4 or more of the crown. First, we will see inflammatory gingival enlargement. The inflammatory gingival enlargement may be chronic or acute. This type of gingival enlargement originates as slight ballooning of interdental papilla and marginal gingiva. In early stages, it appears as a life preserver shape. Here you can see the ballooning of gingiva encircling the teeth in the form of a life preserver shape. The bulge increases in size and it may be localized or generalized, and progress slowly and painlessly unless complicated by trauma or acute infection. It occasionally occurs as discrete, sessile or pedunculated mass resembling tumor. It may be interproximal or on marginal or attached gingiva, may undergo spontaneous reduction followed by exacerbation and continued enlargement. Sometimes it is painful due to ulcerations that occurs in the folds between mass and adjacent gingiva. It may be bluish red, soft friable that bleeds easily and have smooth and shiny surface. Now coming to the etiology of the chronic gingival enlargement, the main etiology is the dental plaque, and factors which favors accumulation and retention of plaque like poor oral hygiene, irritation by anatomical abnormalities and improper restoration and orthodontic appliances. Coming to the histopathology of the chronic gingival enlargement, you can see the exudative and proliferative features in which resembles that of chronic inflammation. There is preponderance of inflammatory cells and fluids, vascular engorgement, new capillaries are formed associated with degenerative changes, lesions are firm, resilient and pink, having a greater fibrotic component with abundance of fibroblast and collagen fibers. This chronic gingival enlargement, it regresses after the treatment automatically. Here you can see the amount of gingival enlargement before treatment, and after treatment it regressed automatically after the removal of etiology. Another type of chronic inflammatory enlargement is gingival enlargement seen in the mouth breathers. Gingival changes associated with mouth breathing are the gingivitis and gingival enlargement, both are seen. Red and edematous with diffuse surface shininess. The maxillary anterior region is commonly involved, and it is attributed to irritation from surface dehydration, and it is present from canine to canine. Yes, you can see it is present from canine to canine only in the areas which are exposed to surface dehydration during mouth breathing. Now, second type of chronic and the second type of inflammatory enlargement is acute inflammatory enlargement. The acute inflammatory enlargement, the first example is gingival abscess. The gingival abscess, you can see it is localized, painful, rapidly expanding lesion that is usually of sudden onset. It is limited mostly to the marginal gingiva or the interdental papilla. It appears as red swelling with a smooth shiny surface in early stages. Within 24 to 48 hours, the lesions become fluctuant and pointed with a surface orifice from which a purulent exudate may be expressed. Adjacent teeth are sensitive to percussion. Here you can see gingival abscess. This is gingival abscess. The gingival abscess, this is an abscess formed due to infection or trauma to the surface of the gum tissue. It is only limited to the marginal gingiva as compared to the periodontal abscess and the periapical abscess. The etiology of this is it results when the bacteria is carried forcefully deep into the tissue due to foreign substance embedded in the tissue. Example, toothbrush bristles. The trauma that occurs due to toothbrush bristles. The histopathology shows it consists of purulent focus in the connective tissue surrounded by polymorphonuclear leukocytes, edematous tissues and vascular engorgement. Surface epithelium has varying degree of intercellular and extracellular edema, invasion by leukocytes, and sometimes ulceration may be seen. The treatment of acute gingival abscess is removal of cause, scaling and root planing follow if not if not if not regressed by non-surgical methods. The incision with number 15 blade on the fluctuant area may be required. The exudate expressed by gentle digital pressure and irrigation with warm saline or water and coverage with the moist gauze, and if required, periodontal surgery. Now coming to the periodontal abscess. Generally, it produces enlargement of gingiva, but they also involve the supporting periodontal tissues. The formation may occur in the following ways. First, by extension of infection from periodontal pocket deep into the supporting periodontal tissues, lateral extensions, pocket with tortuous course, incomplete removal of the calculus, and after trauma to the periodontium. Here you can see periodontal abscess. This type of abscess forms due to the infection that has moved deeper into the gum area. This is sometimes called as gum boil. Here the periodontal abscess, it involves the deeper periodontal tissues and it may also involve the attached gingiva. The treatment of periodontal abscess: drainage through pocket or excision may be required, scaling and root planing, periodontal surgery may be required, systemic antibiotics have to be administered, and in severe cases, tooth removal is if required. Now, this was all about inflammatory type of gingival enlargement. Moving towards drug-induced gingival enlargement. There are certain drugs that when administered for a long duration along with the dental plaque, it causes gingival overgrowth. The family of drugs are mainly anticonvulsants, immunosuppressants, and calcium channel blockers. The anticonvulsants mainly are given in epilepsy patients, and the drugs which causes gingival enlargement are phenytoin, sodium valproate, phenobarbital, and vigabatrin. The immunosuppressant drugs that are mainly given in organ transplant patients and that cause gingival enlargement is cyclosporin. The calcium channel blockers, they are given in hypertensive patients. These are and which causes gingival enlargement are dihydropyridines, nifedipine, philodipine, amlodipine. Other drugs like phenylalkylamine, verapamil, benzodiazepine, and deltiazem. These are the drugs that causes gingival enlargement when administered for a long duration and if dental plaque is present. First, we will see the clinical features of drug-induced gingival enlargement. The growth starts like a bead. The growth starts as a bead-like painless enlargement of interdental papilla. It starts with the interdental papilla. Later enlargement unite may interfere with the occlusion. When not complicated by inflammation, lesion is mulberry shaped, firm, pale, pink and resilient with a minute lobulated surface and no tendency to bleed. The enlargement appears to be separated by linear grooves. Here you can see linear grooves. This makes plaque control difficult and secondary inflammation occurs. It leads to further increase in size and produces red or bluish red discoloration. Here you can see bluish red discoloration, obliterating the lobulated surface and increasing tendency to bleed. Lesion is generalized but is more severe in maxillary and mandibular anterior regions, present only in the dentulous area. This type of gingival enlargement, the drug-induced gingival enlargement, it is not seen in edentulous areas. It creates speech, mastication and tooth eruption. It creates speech, mastication and tooth eruption and aesthetic problems. The histopathology of drug-induced gingival enlargement. Hyperplasia of connective tissue and epithelium is seen. Acanthosis of epithelium, elongated retipegs extending deep into the connective tissue, increased number of fibroblasts and new blood vessels are seen, and abundance of amorphous ground substance is also seen. This type of enlargement, it occurs due to hyperplasia, that is increase in the number of cells. The mechanism of action is the phenantoin. It causes this, it stimulates the fibroblast proliferation, which again leads to the increase in sulfated glycosaminoglycans, which leads to gingival overgrowth. The other mechanism is it causes production. It causes the production of inactive fibroblastic collagenase, which causes the decrease in collagen degradation and again leading to gingival overgrowth. That is, phenantoin, it causes the increase in the number of fibroblasts as well as the decrease in the destruction of collagen fibers that ultimately leads to the gingival overgrowth. These are the pictures of uh, drug-induced gingival enlargement by various drugs. You can see dilantin-induced gingival enlargement, nifedipine-induced gingival enlargement, again deltiazem-induced gingival enlargement, cyclosporin-induced gingival enlargement, and this is a case of combination of drugs like cyclosporin and amlodipine. You can see that it starts with increase in the size of the interdental papilla. The treatment of this type of gingival enlargement, drug-induced gingival enlargement, is first and foremost is the substitution of the drug along with scaling and root planing, that is non-surgical therapy, and oral hygiene instructions. Most of the cases, the gingiva regresses, the gingival overgrowth regresses, and if it does not regresses, if required, gingivectomy or flap surgery may be required. Again, one important type of gingival enlargement is idiopathic gingival enlargement, but it is a rare condition and the cause, the underlying cause is unknown. The clinical features are it involves the attached gingiva, marginal gingiva as well as the interdental papilla. The gingiva is pink, firm, leathery in consistency with characteristics minutely pebbled surface. The facial and lingual surface of maxilla and mandible are generally affected. This is a type of idiopathic gingival enlargement of unknown etiology. Now coming to the third type of gingival enlargement, that is enlargement associated with systemic diseases and conditions. Condition enlargement. The first is the pregnancy. It is a hormonal condition in which which may be marginal and generalized or single or multiple tumor-like masses may be seen. During pregnancy, there is increase in estrogen and progesterone hormonal levels, which induces change in the vascular permeability, leading to the gingival edema, which ultimately increases the inflammatory response of the gingiva. So it does not occurs without local factors. So if the pregnant woman maintains its gingival oral hygiene, then this type of enlargements cannot be seen. And subgingival Coming to the microbiology, the subgingival microbiota P. intermedia is the causative organism which has been found. The second type of condition enlargement is the pregnancy tumor. It is an inflammatory response to the bacterial plaque modified by the patient's condition. It appears after third month of pregnancy but may occur earlier also. It is a discrete mushroom-like flattened spherical mass attached by sessile or pedunculated base that protrudes from gingival margin or the interdental space. It is dusky red or magenta in color with smooth glistening surface and numerous deep red pinpoint markings. This is the pregnancy tumor. It may be stalked, that is pedunculated, or sessile. Coming to the histopathology, you can see the central mass of connective tissue with numerous diffusely arranged, newly formed and engorged capillaries lined by cuboidal epithelial cells. Stratified squamous epithelium thickened with prominent retipex may also be seen. The treatment of this type of enlargement is elimination of local irritants is the first line of treatment. Then scaling and root planing and curettage. Oral hygiene instructions are given to the patient. Only emergency procedures including surgical excision if required. It is to be done in second trimester. Also other procedures are postponed and to be done after pregnancy. Spontaneous reduction is seen after termination of pregnancy in most of the cases. Enlargement in puberty. The clinical features are it is characterized by prominent bulbous interproximal papilla, usually facial papilla. All features related to chronic inflammation with the only difference that plaque is minimum, and after puberty it undergoes regression. It is also a hormonal condition. The histopathology shows chronic inflammation with prominent edema and associated degenerative changes. The treatment of such gingival enlargement is scaling and curettage, plaque control measures, and surgical removal if required. The enlargement due to vitamin C deficiency. The deficiency of vitamin C itself does not cause inflammation, rather changes like hemorrhage, collagen degradation, edema modify the response of gingiva to the plaque. The involvement of marginal gingiva is seen. The gingiva is bluish red, soft friable, and has smooth and shiny surface. Hemorrhage and surface necrosis with pseudomembrane formation is also seen. Here you can see whitish pseudomembrane formation, and you can see the bluish colored gingiva with smooth and shiny surface. The histopathology shows chronic inflammatory cellular infiltration, scattered areas of hemorrhage with engorged capillaries, diffuse edema, cellular collagen degeneration, and scarcity of collagen fibers. Coming to the plasma cell gingivitis. It is an allergic condition with mild marginal gingiva enlarged extending to the attached gingiva. It extends to the attached gingiva. The gingiva is red, friable, sometimes granular, which bleeds easily. The histopathology shows epithelium which shows spongiosis and infiltration with inflammatory cell infiltrates. You can appreciate the abundance of inflammatory infiltration. There is signs of damage of spinous and basal cell layers of the epithelium, and infiltration of plasma cells in the connective tissue is also seen. Coming to the pyogenic granuloma. It is the tumor-like enlargement which is considered as an exaggerated response to minor trauma. It is discrete Spherical tumor-like mass with pedunculated attachment. It is bright red or purple and either firm or friable depending upon the duration. Surface ulceration and purulent exudation may also be present. This is pyogenic granuloma. It may be pedunculated or spherical tumor-like mass. This is also a pyogenic granuloma extending lingually. Histopathology shows mass of granulation tissue with inflammatory cell infiltration, endothelial proliferation and formation of numerous vascular spaces, surface epithelium with atrophic or hyperplastic. Surface epithelium may be atrophic or hyperplastic, and surface ulceration and exudation may be seen. The treatment is only removal of lesion and the etiology. Coming to the systemic diseases that cause gingival enlargement. Systemic diseases that cause gingival enlargement are leukemia and granulomatous diseases. Coming to leukemia, it causes a diffused or marginal enlargement which may be localized or generalized. It may appear as diffuse enlargement of gingival mucosa or an oversized extension of marginal gingiva or discrete tumor-like interproximal mass. The enlargement is bluish red, shiny surface. The consistency is moderately firm but tendency towards friability and hemorrhage occurring spontaneously or on slight irritation. You can see the bluish red shiny surface, and generally the enlargement is diffused in nature, involving the marginal as well as the attached gingiva. The acute necrotizing ulcerative inflammatory involvement is seen. Sometimes it occurs in the crevice formed at junction of enlarged gingiva and the tooth surface. In leukemia, generally the acute myeloid leukemia shows the gingival enlargement. You can see the leukemic gingival enlargement, which is of diffuse nature. The mechanism is leukemic cell infiltration of the gingiva takes place, which leads to the gingival thickening. The thickening of gingiva leads to the formation of gingival pockets. The gingival pockets, it causes accumulation of the plaque, which again causes the appearance of secondary inflammation. And in this way, the leukemic gingival enlargement occurs. Coming to the histopathology, the histopathologic picture shows mature leukocytes and areas of connective tissue which are infiltrated with immature and proliferating leukocytes. Engorged capillaries, edematous, degenerated connective tissue, and epithelium with leukocytic infiltration and edema are found in the histopathology. Meshwork of fibrin, necrotic epithelial cells, polymorphonuclear leukocytes, and bacteria are also found. The treatment is bleeding time and clotting time, platelet count to be checked first, then consultation with the hematologist is very necessary. Removal of the loose deposits with gauze, scaling and root planing, and plaque control instructions are given to the patient. Deep scaling performed at subsequent visits, and antibiotic coverage is of utmost importance. Coming to the granulomatous diseases, Wegener's granulomatosis or strawberry gingiva. It is a rare disease, acute granulomatous necrotizing lesions of the respiratory tract and including the nasal and oral defects. It includes oral mucosal ulceration, gingival enlargement, abnormal tooth mobility, exfoliation of teeth, and delayed healing response. The gingiva is reddish purple in color and bleeds easily. The cause is unknown, and the gingiva, it appears like a strawberry, the external surface of the strawberry with speckled appearance. Here you can see the speckled appearance. It may be generalized or may be localized. The histopathology shows chronic inflammation with scattered giant cells and foci of acute inflammation and microabscesses covered by thin acanthotic epithelium. Coming to the next disease, that is sarcoidosis. It is the disease of unknown etiology, starts at 20 to 30 years of age. It affects the black people. It involves any organ including gingiva. The gingiva is red, smooth, painless, and it is enlarged. Red, smooth, and painless, it is enlarged. The histopathology shows discrete non-caseating whorls of epithelioid cells and multinucleated foreign body type of giant cells with peripheral mononuclear cells, epithelioid cells, and necrotized and discrete non-caseating whorls of epithelioid cells. This was all about systemic diseases and conditions. Now we will see the neoplastic gingival enlargement or gingival tumors. It is the gingival tumors are of two types. Basically, they are benign tumors or malignant tumors. Benign tumors are generally papilla, papilloma, fibroma, etc. First, we will see what is epulis. The term epulis, it is a generic term used clinically to designate for discrete tumor and tumor-like mass of the gingiva. So, first we will see fibroma. The fibroma, it arises from gingival connective tissue or from periodontal ligament. It is slow growing, spherical, and tends to be firm and nodular, but may be soft and vascular, but usually it is pedunculated. The histopathology of fibroma is it is composed of bundles of collagen fibers with scattering of fibrocytes and vascularity. Another variant is also known as periapical ossifying fibroma. This is the picture showing fibroma. It is a benign type of gingival tumor in the maxillary arch. This is the occlusal view. It extends palatally also, displacing the teeth. This is the other type. This is the peripheral fibroma, which may be ossifying in nature. The treatment is first is scaling and root planing, followed by the surgical excision, and if required, the extraction of the tooth. This is the treatment. Incision is given. The flap, periodontal flap is reflected. It is clean. The root surface and the underlying bone is clean. And this is the post-treatment photograph. The other form of gingival tumor, which is benign, is papilloma. Papilloma are proliferation of the surface epithelium associated with human papilloma virus, mainly HPV-6 and HPV-11. It appears as wart-like or cauliflower-like protuberance, can be small and discrete or broad. It is a hard elevations with minutely irregular surfaces. The histopathologic picture shows finger-like projections. Here you can see finger-like projections of surface epithelium which are hyperkeratotic with central core of fibrovascular connective tissue. Central core of fibrovascular connective tissue and finger-like projections of epithelium that are hyperkeratotic. The treatment is surgical excision only. Coming to peripheral giant cell granuloma, It arises interdentally or from the gingival margin. It is frequently present on the labial surfaces. It is sessile or maybe pedunculated. It varies in appearance from smooth regular outline masses to irregularly shaped multilobulated protuberances. Occasionally ulcerations may be seen. It is painless, vary in size, covering several teeth. It is firm or spongy, and the color varies from pink to deep red or purplish blue in color. Sometimes it causes destruction of the underlying bone. The histopathology shows numerous foci of multinuclear giant cells and hemosiderin particles in stroma. Here you can see giant cells. These are the multinucleated giant cells. Overlying epithelium is hyperplastic with ulceration at the base. Bone formation occasionally occurs within the lesion. The treatment is conservative type of excision. The other type is central giant cell granuloma. It arises within the jaw, producing the central cavitation of the jaw. This may lead to the deformity of the jaw. The histopathology shows loose fibrillar connective tissue stroma with interspersed proliferating fibroblast and small capillaries, and the treatment is curettage or surgical excision. Gingival cyst. It is localized enlargement that may involve marginal or the attached gingiva. Gingival cyst. Mandibular canine and premolar are mainly in mandibular canine and premolar. It is mainly seen on the lingual surface. It is painless, but due to expansion, erosion of the bone may cause pain. Histopathology shows lined by thin flattened epithelium with or without localized area of thickening. The treatment is local surgical excision of the lesion, which is recommended. Now coming to the malignant tumors of the gingiva, first is carcinoma. The gingival carcinoma, the gingiva is not a frequent site for malignancy, but squamous cell carcinoma is most common type of carcinoma of the gingiva. It may be exophytic in nature. It may be presenting as irregular outgrowth or ulcerative, causing flat erosive lesions. This is a flat erosive lesion, often symptom free unless complicated by inflammation, locally invasive involving the underlying bone and periodontal ligament, and metastasis confined to above clavicle, may involve lung, liver, or bone. The other type is malignant melanoma. It is a rare tumor, tends to occur in hard palate and maxillary gingiva of older persons. It is darkly pigmented, flat or nodular with rapid growth and early metastasis. It arises from melanoblast in the gingiva, cheek or palate. Metastasis to the underlying bone and cervical and axillary lymph nodes are common. Coming to sarcoma. Sarcomas like fibrosarcoma, lymphosarcoma, and reticulum cell sarcoma are seen in gingiva, but they are usually rare. Kaposis sarcoma often occur in the oral cavity with the AIDS patient, particularly in the palate and gingiva, and the metastasis occurs infrequently in gingiva. Now coming to the last type, that is the false enlargement. The clinical feature shows, as the name suggests, they are not true enlargements and may appear as such as a result of increase of size of the underlying osseous or dental tissues. The underlying osseous lesions are enlargement of bones subjacent to the gingival area occurs in tori and exostosis. Here you can see multiple tori in the lingual surface of the mandible. Paget's disease, fibrous dysplasia, cherubism, ameloblastoma, osteoma, and osseous sarcoma. In this, the enlargement of gingiva does not occur, only the enlargement of the underlying structure occurs and which leads to the picture of gingival enlargement. So it is termed as false gingival enlargement. Underlying dental tissues that may lead to the false gingival enlargement picture are during the stage of eruption of the permanent teeth, particularly in the primary dentition, the labial gingiva may show a bulbous marginal distortion showing as the enlargement of the gingiva, and this is termed as developmental enlargement. This is physiologic and may get complicated by inflammation. This was all about gingival enlargement. Now, the frequently asked questions in this in this gingival enlargement is this topic is of importance for the long question point of view. Long question like classify gingival enlargement and describe the different types of gingival enlargement may be asked, or short questions like differentiate between periapical abscess, gingival abscess and periodontal abscess. Questions like drug-induced gingival enlargement may also be asked. These are some of the important type of questions. Thank you.